Okay, so let's dive into these osteochondroma notes. The plan is to pull out all the crucial bits you need, make it stick, without feeling overwhelmed.
Exactly. We're zeroing in on the absolute need-to-knows for this condition. It is the most common benign bone tumor, after all.
Right. So first things first, what is an osteochondroma in simple terms?
Well, fundamentally, it's a non-cancerous bone growth. It kind of sticks out from the bone surface, and importantly, it has a cartilage cap on top.
Like a little bony mushroom with a cartilage top.
Precisely, or like you said earlier, a little bone wearing a cartilage hat. They usually show up when kids or teens are growing
Near the
fast.
growth plates, I imagine.
Spot on. They develop near the growth plates of long bones, mainly. And remember that memory tip? Osteo for bone, chondro for cartilage, osteochondroma helps lock it in.
Osteochondroma, bone, and cartilage. Got it. So characteristics, where do they pop up?
Usually the long bones like femur, tibia, humerus, near the ends, that's the metaphysis, near the growth plate, they can be stalk-like, that's pedunculated.
Or more flat and broad?
Mm-hmm.
Sessile?
Exactly, Cecil. And you might just find one, or sometimes people have multiple. Often, an adolescent might just notice a hard, maybe slightly bumpy lump near a joint.
And it grows with the person.
Yes, it grows as the skeleton grows and usually stops when skeletal maturity is reached. Often presents as just a painless lump, maybe some joint aches nearby.
Okay. What actually kicks these off? The etiology.
Yeah, the exact trigger isn't fully known. The main theory involves some kind of, well, glitch or displacement of a bit of the growth plate cartilage during development.
A developmental hiccup, sort of.
That's a good way to put it. And there might be a genetic link, especially in cases where someone has many of them, a condition called multiple hereditary exostoses.
Makes sense. And who's typically at risk?
Primarily kids and teenagers, right in those peak growth phases. Beyond that link to skeletal growth, there aren't really any other clearly defined risk factors. It can happen to anyone.
Right. So drilling down a bit, the pathophysiology, what's happening at the tissue level.
So it stems from that abnormal activity at the edge of the growth plate. A bit of cartilage gets displaced and keeps growing, forming bone beneath it, creating that projection with its cartilage cap.
And they tend to favor the ends of long bones.
Predominantly, yes, near the knees, shoulders, hips. But they can technically occur on flat bones too, like the pelvis or scapula.
Okay. Now, if a doctor suspects one, what else could be on the differential list?
Good question. You'd consider other benign things like osteomas or enchondromas, but critically, you need to rule out chondrosarcoma, which is malignant.
That's the serious one.
Definitely. That's why imaging is so key, and sometimes looking at the tissue itself, histopathology is needed to be absolutely sure, especially with the cartilage cap thickness.
How common are we talking? Epidemiology.
They're actually the rock stars of benign bone tumors. In the UK, something like 35% of all benign bone tumors are osteochondromas.
Wow, that common?
Yep. And they don't really discriminate based on ethnicity or gender. Pretty equal opportunity growths.
So what might someone actually notice? The clinical features.
Often, absolutely nothing. Many are found completely by chance on an X-ray done for something else. They're asymptomatic.
But if they cause symptoms?
Then you might get a visible or palpable bony lump, maybe some pain if it's pressing on things or due to bursitis over it, sometimes limited movement in the nearby joint, or nerve compression.
Ah, the nerve compression, like the peroneal nerve you mentioned.
Exactly, near the fibular head. That can cause foot drop or altered sensation. So a quick memory jog: pain, palpable lump, pressure on nerves or vessels. The 3 Ps again.
Pain, palpable, pressure.
Yeah.
Easy enough. How do doctors confirm it then? Investigations.
Imaging is the mainstay. An X-ray is usually the first port of call. It has a pretty characteristic appearance, pointing away from the nearest joint.
And if more detail is needed.
Then CT or MRI scans come in. They're great for seeing the exact size, the cartilage cap thickness, which is important for ruling out malignancy and its relationship to surrounding structures like nerves and vessels. A biopsy is less common, usually reserved for atypical cases or if there's suspicion of change.
Okay, so diagnosis made. What's the management plan?
Well, if it's small, stable, and not causing any bother, the usual approach is just watchful waiting. Keep an eye on it with occasional checkups or imaging. No active treatment needed.
And if it is causing problems, pain, nerve issues?
Then surgery to remove it and excision might be the way to go. The decision really depends on the symptoms, the location, the size, and potential risks.
What's the typical outcome? The prognosis?
Generally, it's really good. These are benign lesions. If they're fully removed surgically, recurrence is uncommon. And even those just monitored usually remain stable and harmless. excellent long-term outlook.
That's reassuring.
Yeah.
Are there any potential downsides or complications to be aware of?
But for the most part, no. But potential issues, though relatively rare, can include things like fracture through the stalk of a pedunculated one, bony deformities if it affects growth, joint problems, that nerve or vascular compression we talked about.
Right.
And the big one, though very rare, less than 1% risk for solitary ones, is malignant transformation into a chondrosarcoma.
Okay, less than 1%. Is that risk higher in some cases?
Yes, slightly higher risk if someone has multiple osteochondromas, hereditary multiple exostoses, or if the lesion is located more centrally, like in the pelvis. Changes like sudden growth or new pain in adulthood raise suspicion.
Got it. So summing up for revision, osteochondromas, common benign bone and cartilage growths, near growth plates, often zero symptoms, usually great prognosis.
Exactly. Key things to flag are those potential complications like nerve compression, remember the peroneal nerve, and that small risk of malignant change, especially in specific contexts.
Perfect. That really crystallizes it. And for anyone wanting to really nail this for their MSRA, where should they head?
Definitely check out pastthemsra.com for more comprehensive resources, and don't forget the free materials available at freemsra.com. Always good stuff there, too.
Brilliant. Hopefully this deep dive gives you that clear, high-yield overview you need. You've got the essentials now.